remember the biomechanical aspects explained yesterday, and for the explanation purpose, we'll assume we do mechanical alignment TKRs like most of the TKR surgeons do, and I will just again explain you the difference between that and the kinematic alignment. Uh, so I hope there is no doubt with the indications, although it differs by surgeon to surgeon, but there are some set indications which you have to go through to uh, understand the and able to write in the exam. That I'm not going to discuss. And so we'll start with the approaches. Okay. So we'll start with the approaches. We have the standard medial parapatellar approach. Parapatellar approach. Most of the in most of the conditions scenarios you can get away with this approach. Here you will take a median or a paramedian incision on the medial aspect of the knee. So if you this is a knee, it's the tibia, and this is the ligamentum patellae. So either you will take a central incision or a paramedial incision, and the paramedial incision has its few advantages. Like if this gets scarred, it may stuck to the extensor apparatus, and further exposure in the revision surgeries are difficult. And second thing is, if it gets into a hypertrophic scar or keloid, then it may cause some problem with kneeling on the knees. So there is no much difference though, but this has some kind of an advantages, like you can you can prevent this scar sticking to the extensor apparatus. And then once we are done with the incision, then we have rectus with its tendon. We have vastus lateralis, vastus medialis, and their tendons and expansion. Okay, so we go between the interval of color change. So we go in this interval, keeping around 4 to 5 mm of cuff around the patella and patellar tendon between the rectus and the vastus medialis. So this is the classical paramedial approach, medial parapatellar approach. And if some issues with this are, it gives an excellent exposure, no doubt. But it is critically acclaimed that in the post-operative period, there is of course there is a dissociation of rectus and vastus medialis from the rectus vascularis to the vastus medialis. So however effectively you close this interval, there is some insufficiency of the action caused by the vastus medialis in the extension, and they will have some amount of extensor lag, and they may require a prolonged time for the rehabilitation to strengthen the quadriceps. So some people who try to preserve as much quadriceps as possible, which is attached to the patella. And then came the concepts of mid-vastus and sub-vastus approach. In the mid-vastus approach, we take the approach same below the patella and patellar tendon and the with a cuff of around 45 mm. But in the quadriceps muscle, we go along the we go rather in the interval, we go in the vastus medialis, along the fibers of the vastus medialis, and we split them. Along the fibers of the vastus medialis, we split the quadriceps so that there is no dissociation of these four muscles interlinked together. Since it is just a split along the fibers, there is no actual cutting of the muscle fibers. And they observed these patients to have a more of a quick rehabilitation and less of a extensor lag. And some people even went ahead and they told, we will not touch the entire quadriceps mechanism, and they started approaching this through the subvastus manner. That is the entirely leaving not untouched quadriceps and going in the this dissecting through the uh, medial retinaculum and the medial uh, muscular interval, that is the medial intermuscular septum, medial retinaculum, and keeping whole of the quadriceps untouched. And though these were practically useful in preserving the quadriceps, but the difficulty is there with the exposure, because this is going towards mid side, and subluxating the patella laterally is an issue. But if you do your approach good, dissect out, and it may require a bit of a longer incision though in the skin, but people have said there is no difficulties as such. If at all there is a real scenario of there are some other extensile approaches which you can incorporate to get the approach. Okay, so these are the variants you can say of the middle parapatellar approach, just with the aim of preserving as much quadriceps as possible. Okay, so there are some of the extensile approach, most of all are described by either Insal, Ranawat, or Whiteside. So first is the quadriceps snip. This is by Insal. So what is done is, you have rectus, you have lateralis, and you have medialis. You have the patellar tendon. You go as you have in the medial parapatellar approach, you go in the interval, and you take another horizontal or a 45-degree angled incision in the rectus musculotendinous junction along the fibers of the vastus lateralis, and this will create a more mobile kind of a thing to evert, and this will aid in the exposure. Okay, so 2019 JOA Danbury paper, they have tested more than 321 patients and followed up for more than 10 years, and they said this will not make any quadriceps weak. So there is no additional uh, issues with the rehabilitation or longer duration, and there need not be any change in the rehabilitation program. And the risk of quadriceps or the extensor mechanism ruptures were same as of a simple medial parapatellar approach, or with the approach with the quadriceps snip. So this is an effective way. Whenever there is an issue with the exposure, you can rely on this, and it's a it's a little modification which will give you a lot. And the second thing is something called as a uh, there is a quadriceps lengthening which can be done. That is a VY lengthening. This is by Scott Skiliski. What is done here is what is done here is you have a extensor apparatus, and you go medial parapatellar wise, and you take a V incision at the this one, the intermuscular septum of the rectus, and you flex it as much as you want, and it looks ultimately like this. Means you pull this down and you attach these two, whatever a gap is there, and then the pull which is here is tied like this. It would be good if I show you the picture. I'll show you at the end of the. This is just like a VY plasty. You do a V and then you Y it. Okay, so you take like this, and this part you suture it, and this V. So this V to Y lengthening, it is the same here also. I'm not able to draw it here, but it is the same. You have a V incision, which you will change it to a Y by approximating this and lengthening this. Okay, so this is one of the way of lengthening the quadriceps. I will show you the picture by the end of this lecture. And the third thing is a tibial tuberosity osteotomy. Okay, this is by Whiteside and all. What it is said is you have a patella, you have patellar tendon, and you take around 8 to 10 centimeters of tibial tuberosity, anterior aspect of the tibia, the anterior crest of the tibia, and will you don't put any spikes, or you will not dissect on the lateral or the anterior compartment of the proximal tibia, and you make a saw hole here through and through, and you flip the entire thing on the lateral side. Okay, so if this is a proximal tibia, so then you start making a slit here for around an 8 to 10 centimeters, and you will not dissect on the anterior aspect because that has some vascular connections with the proximal tibia, so and the periosteum. So you will dissect on the medial aspect. You will take a saw, you will saw it out from around 8 to 10 centimeters, and you release all the adhesions whatever are there, and you entirely uh, just subluxate the patella on the lateral side. Okay, so this is one way in which you can. This is medial side, this is lateral side. So you वीडियो आएगा क्या? आ सकता है अगर तूने यूट्यूब पे ज्वाइन खोला तो ठीक है ठीक है ये शेयर हो रहा है. So what you will do, you will take a saw here. Okay, so you will saw it out through and through, but you will not dissect on the lateral aspect. and people are said you make a rounded diet so that it doesn't act as a stress riser. And preoperatively, you can make drill holes if you are not planning for advancement or the proximal slide or the distal advancement. You can already drill hole the screw sides for the ease in the post in the at the end of the closure when you fix this tubal tuberosity fragment, and then with the whole of this the rectus versus medialis interval, cuff around the patellar tendon, and along with this tubal tuberosity fragment, you subluxate it lateral side. You subluxate it lateral side to have an excellent exposure. Okay, and there is a maneuver. It's not a it's not a exposure technique. It is just that it is called Ransel's technique, Ranawat and Insal technique. That is to external rotate the foot so that the tibia, the patella is easily subluxated on the lateral side. This you might have observed. Once we take a parapatellar approach, we external rotate. If I have done a medial parapatellar approach, we external rotate the foot so that the patella is subluxated laterally easily along, because the tibial tuberosity is an external torsion, so that takes the patella with it to translate the subluxate laterally. Okay, these are with the exposures. And then coming to the cuts properly. So once you, the important thing to address before taking any cuts is that there is a concept of measured resection or a matched resection and gap balancing. Okay, so measured resection is nothing but you will cut as much you replace. Okay, so the most of the standard implants, the thickness of the femur is around 9 mm, and the tibial base plate is around 2 to 3 mm, and you have a poly starting mostly from 6 or 7 mm. Okay, so this is, I mean, many of the companies have different uh, dimensions, but I would say this is the most common one, with the femur size starting from around 9 mm, with a tibial base plate of around 2 to 3 mm, and you have a poly which starts by around 6 to 7 mm. Okay, so it with this, to the new joint line which you're going to form is between this femur and this poly. Okay, so this you have to replicate preoperative, like preoperatively. So you cut the femur 9 mm all around the femur, and you replace that with the prosthesis, and you take a cut of 9 mm, around 9 mm in the tibia, and you replace it with the implant. So this is the condition in most of the this is the this is a thing which is done in most of the surgeries which are not that significantly deformed. Okay, so but this is not the condition always, because sometimes what happens is you have a deformity, either a valgus or a varus, with an asymmetric gap in between. So if you cut uh, you know uh, like a measured resection, then you will not be able to correct the deformity. Okay, so in such cases, you will have to do something called as gap balancing. And there is a strong consensus that the when these I think I had explained the evolution of implants yesterday, so I'll just touch it once because that is useful for us. The when 1973, the Insal, Scott, and Kelly, they started with something called as total condylar knees. So before that, many people have tried, and all of them were the fixed hinge type, which failed terribly because they did not address the very important mechanical aspects. They just thought it is a simple hinge, and they did a fixed hinge, and it failed terribly. So then came this concept of total condylar knee, preserving as much as uh, bone possible, and having a joint which is a semi-constrained type, allowing for the normal mechanics not disturbed. So what they did is they did something called as a measured resection techniques, and mm, they cut as much as they replace, and the implant was bicruciate, sacrificing total condylar knee. So they cut both the cruciates, and they resect out the bone, and they replace it with a design with the processes which they had designed. But the early problems which they encountered were two. In a very near future, just in a 2 or 3 year post-op period, they addressed. One is the patellofemoral issues, that we'll address later, and second one is the decreased range of motion. Since they took out both the cruciates, there was no nothing to get the femoral rollback mechanism back. So the maximum flexion attained was around 90 to 95 degree. So then came the importance of PCL, and then they said, this is required for the rollback, and then came a duopatellar duopatellar implant, the processes, the design. They retained the PCL, and they had a slit in the tibia for the PCL, and the same notch in the femur, and they used pegs for the anchorage to the bone, and they had a button like patella which resurfaced the patella. But initially there were two separate polys, and later they changed to a one, and that design is a kinematic prosthesis. These duopatellar and kinematic processes are the precursors for the cruciate retaining knees. It was like Insal did not settle with his design, and he continued research, is doing research, and he found out that reasons for the his design failure was a ineffective femoral rollback. So then this Insal and Burstein, they designed a cam post mechanism to have a effective rollback, and they term these implants as the posterior stabilized or PCL substituting. Okay, so it is not that the PCL sacrificing and PCL substituting are same. No, PCL sacrificing it's a bicruciate removed without cam post. That is the earlier designs, or a newer design which is called as deep dish, which is of more conformation to the femur, and this increased anterior constraint will not let the tibia to translate posteriorly. So this is the posterior PCL sacrificing uh, type. But the one which has a cam post mechanism, it is called a PCL substituting or a posterior stabilized implants, which is a constraint type of processes. And the other one is the cruciate retaining with the PCL intact. Okay. So why I started with this is that key the initially when they started with it was a PCL sacrificing, and there were issues with femoral rollback and patellofemoral other things, and then the cruciate retaining, and then the PCL substituting or posterior stabilize. So gap balancing with these different implants are different ways, like it is different with different kind. So before I go into the cuts and the measured resection per se, so I would just like to highlight the differences between CR, PS, and some points on the other constraint and hinge models. Okay. Okay. So we know that since we are retaining the cruciate, so we need not take a cut which accommodates the cam post mechanism. So in PS, as you know, you will have to accommodate the cam post mechanism. So you will take some amount of distal femur cut as a third condyle and make a box which allows for the cam and the post. Okay. So since you are retaining the PCL, which will effectively take care of the femoral rollback, you don't require this third condyle cut. So CR is kind of a bone preserving surgery than the PS. So it has got a theoretical lessened risk of condylar fracture, so the supracondylar fracture, than the PS. And second thing is you have a natural PCL, which will have a more natural femoral rollback, and it is seen that the gait of a postoperative CR knees have a symmetric gait of a normal uh, knees. It has a more symmetric gait pattern. Okay, it has a more symmetric gait pattern. And the other thing is PCL will not allow, or otherwise I say ki, the gap created in with preservation of PCL is very less that you have to balance it. So the cruciate retaining knees will not tolerate much of a joint line elevation or a depression. So you will have to juggle with the gap, keeping the PCL. So this will maintain it one of a tether, so that it will not allow any much joint line elevation or a depression. So the change in the joint line as of preoperative joint line is very less, or you can say no, with the uh, CR. So why it is important is ki if you see PS, there's I think this Eng and English have shown that if you cut PCL, it increases flexion gap by around 4 to 6 mm. But whereas it it only increases extension gap by less than 2 mm. So it is a situation where you have a asymmetric flexion and extension gap which you have to balance. So what you will do, you will eventually take a more of a distal femoral cut, that is the anteroposterior cut, to balance the increased flexion gap. So rather having a if this is the distal femur, so rather having a joint line here, since you have cut the more of a distal femur to match the increased flexion gap, so you will eventually use a little thicker poly, and there is a, invariably a increase in the joint line. Okay, so there is an invariable joint line elevation in post stabilized knees, and the patellofemoral mechanics is very much dependent on this joint line, because there is something called as 4-bar linkage concept. 4-bar linkage concept, which is with the cruciates, the quadriceps, patella, and the patellar tendon. So these 1, 2, 3, 4. These four will act with each other to have a perfect mechanics of the knee. Since we are taking cruciates out of the box, these two still tries to act with each other, and they need to be stressed as or, you have to keep the strain of these two as of a preoperative strain, otherwise they fail. And so by elevating joint line, so you are gonna change this mechanics of a patellofemoral joint. So there is some issues with the patellofemoral the patellofemoral mechanics, and that may lead to a patellofemoral arthritis. And if it is too much, if you have elevated the joint line more than around 4 mm, there are issues like patellar subluxation, patellar abnormal tilting, and dislocations. Okay, to make it constrained in the trochlea, you may use a thicker button, and that will overstuff, stuffs like that, which is there in the models with PS. uh, okay, and the other thing is of course PCL is a ligament which has mechanoceptors, and it is involved in the proprioception. So patients post-operatively feel more of a native knee in cruciate retainings, than of a uh, posterior stabilized. And the other thing is there is something called as patellar clunk syndrome. Patellar clunk syndrome. What happens is you have a quadriceps, you have patella, and you have patellar tendon, and there is a fat pad, between the this suprapatellar pouch and the quadriceps muscle, and okay, so you have this fat pad. So once you replace with the posterior stabilized, so you have a bigger box, with a bigger notch here. Okay, so there is a notch, a third condylar notch. This is how it looks with the cam behind. So you have a notch here, which is bigger to accommodate the cam post mechanism. Okay, so what happens if you don't take out this pad of fat? Then on every time there is a flexion extension, this fat pad is stuck in the sharp this notch, and it starts forming the nodule there. Okay, so the flexion extension will not be a smooth process. As it goes on, there is a fibrosis of this nodule, and this will stuck at the notch, and you literally have to put efforts to take out that nodule from this notch. And this is a typical complication of posterior stabilized knees, because CRs don't have a bigger notch of posterior stabilized. So it is a typical complication of posterior stabilized. So this you can get away by taking this more of the fat pad. But some people have again objected that it carries some of the vascularity to the patellar tendon and patella. So by denuding this may have effects on vascularity of the patella and patellar tendon. Okay, and other thing is when you have a periprosthetic fracture of the femur, periprosthetic fracture of the femur. So one of the way is do a retrograde nailing to have a open reduction and internal fixation for this periprosthetic fracture. Uh, I will talk in detail about periprosthetic fracture, its classification and other things. So if the implant is stable, for now, if the implant is stable and if you have a supracondylar femur fracture, one of the ways is to do a retrograde nailing, which is allowed in CR with ease because you don't have a box to accommodate the cam post mechanism. So you can easily have intramedullary access through the notch in the CR. But whereas in PS, you will have to burr out the box with the diamond tip burr to get the access into the intramedullary cavity if you are planning for retrograde nail. Okay, so this is a one theoretical advantage which CR has, but ultimately these are the points which you can answer in the exams, but it entirely depends on the way you have your expertise, because CR is considered as a difficult surgery. you know in the Western, they have a set of rules like surgeon can only do CR if he is doing more than 20 TKRs per year. You know, because it is a difficult surgery, it cannot be done by a inexperienced surgeon. It requires expertise and experience. So for the ease, if you are starting with, is recommended is doing a posture stabilized, because balancing is easier and there is a error of margin for your which is forgiving, but CR has to be precise. You cannot have you cannot have any instabilities left. You have to balance it very precisely. And okay, this is about the CR. But again, the literature is though it doesn't have any much difference between CR and PS. So you should consider cruciate retaining processes as one of your processes in your armamentarium and use it judiciously, and with a selection, with a properly selected indicated patients. There is no bias in the CR or PS. It is just that one of the processes which you have. And another thing which differs between PS and CR is, since PS being a more constrained, that is of course the rollback is because of the uh, cam and post. So this cam touches the post by around 60 70 degrees, and this will prevent the uh, anterior translation of femur. So each time a patient flexes, there is a lot of strain transmitted to this cam and post, because it has to act as a constraint, and this is transmitted to the prosthesis cement bone interface. And there is an increase there is a possibility of an increased osteolysis and loosening because of this strain transfer the stresses or strain transmitting to the prosthesis cement and bone interface. So if you want, you have a Mayo a paper. They have studied more than 3,000, 4,000 CRs and PS, and they said the 10 15 year survival in PS is around 89%, and in case of CRs, it is around 95, 97%. So again, these are all the figures, but ultimately you are the surgeon who uses the best use of these implants. They are just the implants. They don't carry any inherent advantages as such. It is the way they are used. Okay, so moving on, we have a more constraint models like a varus valgus constraint. Varus valgus constraint, they are called total condylar third generation or constraint condylar design, constraint condylar knees. So I think CCKs of Zimmer, uh, yeah, TC3 is debut, I think. So what they have is you have a post which is not it is not just made enough to block the cam. They have they have increased the length of the post, and just making a cam on the femur, rather you make a side walls to the femoral prosthesis which grasp this post, and this will not allow the varus valgus forces which are constrained by these side walls by the increased length of this post. Though there is some amount of toggling, but it is one of the ways in which you can have a varus valgus constraint. So the indication for this is very, very precise, that you will have to have a collaterals. You cannot use it where they are torn or they are degenerated torn or traumatically torn, but you feel they're insufficient or there is a difficulty in balancing out. There is a huge insufficient because over the period of time, there is a fatigue failure of the fibers, and rather they get torn, they lengthen themselves. So they become inefficient, though they are not cut as such. So these are the conditions in which you can use these constraints, or if the one of the other indication is inadvertently or iatrogenic insult to the collaterals. So instead of apart from repairing that, to reinforce the uh, total joint, you can rather shift to a more constrained varus valgus designs. That will have inherent stability, which allows these iatrogenic damages to heal, and they will not fail. Okay, so moving on, you know um, we have a more constraint we have more constraint models of called hinge total knees. So there are two varieties. One is with a fixed hinge, which is almost obsolete because it will not allow a rotatory motion which happens in normal knee. It is not a simple hinge, as I have explained yesterday. So we have a rotatory hinge. So it is nothing but you have a long rod which goes in the femur, and this will have a global stability with the rotation. So you are not locking something like you are not locking a hinge like this. You're not locking hinge like if you have seen total elbow, you know what is hinge at once, what is fixed hinge. If you lock this, there is no rotation. It just allows the flexion extension, the hinge. So here it is not fixed. It rather has a huge barrel in the femur, and in that goes the huge danda of the tibia. Okay. This allows rotations, however, but it will not allow any anteroposterior mediolateral instabilities. And as you go through the survivorship of these implants, it is observed that the amount of constraint, the increase in the constraint in the model decreases the survivorship for the simple fact that the constraint is borne by the implant, and that is ultimately shared and ultimately transmitted at the bone, this processes bone interface, and that will lead to a early loosening or a loosening and osteolysis. So for obvious reasons, so as you increase the constraint, there is issues with the early failures and lessened survivorship. Otherwise, everyone would have, because the surgery of hinge knee is very simple, so everyone would have used it because of these issues. So you'll have to choose implants, and it is like use as much only to address the issues, and not overdo it or over treat it. Okay, so this is about the implants and their types. And one very interesting, these guys, there's a Frederick Buchel and Michael Papas. They came up with a concept that if you fix the poly to the tibia, then in case of rotations which are gonna happen, so they observe that there is a increase in the wear rate of the poly, because since it is fixed to the tibia, it will not allow for the free movement of the poly. So they started with something called as low contact stress or meniscal bearing or mobile bearing model, which has something called as a flat base, and with a peg in the, or a hole in the this one, and on which the poly sits freely with its peg inside, and this will allow a free rotations of the poly. There is no attachment of this poly to the tibial base plate. So the proposed advantages of this are, there is a rotations which are taking place at the poly level, and they are not transmitting to the the tibial base. So there is a theoretical proposed advantage of lessened stress transmission and lessened tibial loosening. And the other thing is, if you have a somewhat some amount of malpositioning of the components, but because of this free mobile poly, it itself gets a congruent, it itself gets aligned itself to the femoral component, irrespective of the base plate anchorage to the bone. Even if you have somehow internal rotated the tibia or some excessive external rotations, this is free. This is not attached here. So the tibia, the poly will get itself, change itself to be congruent to the femur, and some levy is possible, and your errors in the component malpositionings. So yeah, these are the advantages of this meniscal bearing, but still they are like a, there's some C or D FDA, third or fourth FDA grade in which it comes. That means they don't have proven advantages or risks assessment, but they seem to have some amount of advantages. So they can be used in selected cases after approval by FDAs. They're still yet to emerge in the market as free as other implants. So now if you have a justification, then you can use them. It's not freely available. So for the same reason, the not many companies have these manufacturings. Okay, these are about the implants. And coming to the gap balancing, it is a simple concept that you have to balance the extension gap equal to flexion gap for the easy sliding of the articulations between the femur and the tibia. So so what happens is, if this is a femur, this is tibia, you will cut tibia and you will take a cut in the distal femur, and this gap is called the extension gap. And then when you flex it, this you have already taken, and you will cut the posterior condyle, and this distance is the flexion gap. This is an extension gap. Okay, so your aim is to balance these two so that when tibia flexors extends, there is a smooth gliding, a smooth rolling of the uh, articulation between femur and tibia. So so how it is exactly done is we'll go through step by step. um, yeah, so once you have done your approach, once you have exposed the articulation, once you have exposed the knee, what you will do, you will subperiostally elevate the anteromedial capsule from the tibia, and you go slightly around to release the deep MCL, and you will knock off the medial and lateral menisci, and you will take out the fat pad in the behind the patella, just so much as to have a better exposure. Once you have done that, then you have a jig. They come in cutting jigs. They can be either intramedullary or extramedullary. So obviously this intramedullary has to go inside the medullary cavity. They have a risk of the fat embolisms, and other thing is, since it has to negotiate through the medullary cavity, if you have an extra articular deformity, you cannot use this. And these are the advantages of the extramedullary. The risk of fat embolism is less or nil, and you can use it in cases of extra articular deformities. Yeah, so mostly we will use a extramedullary jig for the tibia, and we use an intramedullary jig for the femur, because in the femur, using an extramedullary is difficult because you have an exposed ankle, you have a palpable anterior crest, you have a shin which you can align with the jig, but whereas a bulky thigh will not let you know where the femur is or where the center of the head is. So you will use an intramedullary jig in cases of femur, and you will use a extramedullary jig for the tibia. So to start with, most of the surgeons will take a proximal tibial cut first, and then the distal femur. You can do it otherwise also. That there is no issues with that. So will you study as it is seen. So this is tibia, and this is ankle, and this is shin. Okay, so you have a extramedullary jig with two clips like this, which anchors at the ankle, and you have a semicircular jig here, and here you have three plane of change with this jig. So this bar will allows for a varus and valgus, like this or this, and there is a danda here. If you take behind and anterior, it changes the slope of the tibia. Okay, so yeah, and you have rotation is important in when you are implanting the uh, prosthesis. So for now, if for the proximal tibial cut, you have to precisely adjust the slope and the varus valgus, varus or valgus cut. Okay, so as we studied yesterday, most of the surgeons will align to the mechanical alignment. So we will take a cut perpendicular to the mechanical axis of the tibia. If you are contemplating a kinematic alignment, then you will have to take a 3-degree varus cut, to align it to the parallel to the ground. So doing it in the free hand with the extra-articular jig is a difficult thing. So for which you at least require an accelerometer based or a computer navigation or a robotics. So for we will stick to mechanical alignment TKRs. So you will take a perpendicular cut, and the slope is adjusted according to the implant instructions, because many of the processes have their inbuilt slopes. So you'll have to consider that. And in cases of PS, it is said that you will take a cut which is almost 0 degree, because for the effective use of the cam post is best when it is parallel. So in PS, tendency is to have a parallel cut, but whereas in CR, since you have to get the same strain in the PCL as of preoperative for the better functionality in postoperative period, so you will have to mimic each of the steps like a native knee. So you will try to mimic a slope of a preoperative knee which you have calculated from the preoperative planning. Okay, so yeah, so likewise you will adjust the slope and the varus valgus, and you will take a proximal tibial cut. So the steps which I'm gonna explain, which I am explaining, is assume that you had a patient with the bicompartmental osteoarthritis, and the deformity seems to be correctable after anesthesia, or after once you take out all the osteophytes and release some amount of the this deep MCL and other things. Okay, so it's more of a simple procedure, and the complexities we'll discuss later, like what are the steps in the varus valgus flexion recurvatum. Okay, so this is a simple case which most of the times, you know is what is happening. You have a patient with a correctable varus, so there is no issues with the soft tissues, and not much of a gap balancing is required. So you will do what I am going to explain now. And once you adjust the slope and varus valgus, you have you have something like this with a metal slide, and a gradations, and a marker like this. Okay, so which you can mount on this a cutting jig. And as we know, varus deformity is the most common in osteoarthritis. So the medial condyle is somewhat is sorry, the medial condyle is somewhat flattened or it is worn off. So if you measure the thickness from the lateral condyle, so if you measure from the medial condyle, then you are leaving that amount of worn tissue from the measurement. Okay, so you will have to address that, otherwise you will be cutting more. So if you consider you're planning to take a 7 or 8 cut, and there is around a 1 to 2 cartilage or which is worn on the medial side, and if you measure from the medial aspect, then you will almost cutting around 10 Okay, so it is advised that, so if you are using on the medial side, you take a 2 less cut, as you like. If you are planning for uh, 8 cut, so you keep the, you can fix this, you can fix the gradations with this marker, and you fix it to a 6 level with the additional 2 considering the lost cartilage. Okay, so this is a bit cumbersome. So what most of the people does is they take a almost pristine lateral compartment. Many of the times the lateral compartment is preserved. Okay, so you assess what is the amount of wear. If you feel there is a uh, there is some amount of wear, so then you adjust accordingly. So the idea is that you cut appropriately considering all these bone tissues, because the soft tissues are kind of a, kind of a acquainted with the tissue which was there. Like, it is not that you know since it is a correctable thing, the soft tissues are balanced according to that preoperative state, like the normal state. So you will have to respect that, and you will address this last bone tissue when you take a cut. So with all this keeping in mind, you take a proximal tibial cut. Okay, you have something like this. You have a proximal tibial cut, and then you have a distal femur. You have to cut a distal femur to know the extension gap, and accordingly you can match that with the flexion gap. Okay, so here we flex the so you flex it. So sorry, you flex it, and then you have something called as a, okay, this is the axial profile of the distal femur, and you have a transepicondylar line, and you have a anteroposterior axis of the sulcus, you know. So this line is called as Whiteside's line. Whiteside's line with a line along the sulcus of the this patellar trochlear groove. So usually, this transepicondylar and the confluence of this Whiteside's line, and around 5 around some 2 to 3 medial to this, you take an entry point. Or some people say you have a PCL insertion, and around 5 to 7 above, you in line with the PCL insertion, you take a entry point, you enter the medullary cavity, you give a thorough lavage, you take out all the fat, and you will you'll have an intramedullary jig, which is a really long one, almost reaching up to the isthmus, because you don't want any toggling, because the distal femur is somewhat broadened like this. Okay, so you have a short something like this, so it can toggle around and your cuts are affected. So you have a really long intramedullary jig which almost goes at the isthmus and it snugly fits. So by doing this, you have aligned your intramedullary jig to the anatomical axis of the femur. Okay, so as you know, the mechanical axis, the anatomical axis is 6 degree valgus to the 6 degree valgus to the mechanical axis, and now we are dealing with something to align our processes perpendicular to the mechanical axis, since we are dealing with the uh, mechanical axis, mechanical alignment. So the next cutting jig, it comes like this. Okay, you have a shimmer like this with the intramedullary axis, and you have a block which is applied here, and in this you have slots to have a jig here. Okay, this is how it comes. Just a schematic diagram, and this block is the one which you know you have to adjust for your valgus. Okay, so you have few companies with a one block and a dialing in that, where you can change the angle of valgus, or in Smith and Nephews and other companies, you have a different blocks altogether for each degrees. So they have 3 degree, 6 degree, and 9 degree blocks for this valgus curve. And as we know, the anatomical axis is 6 degree to the mechanical axis. We use a 6 degree valgus cutting block which will align like this, somehow like this. Uh, as you know, you have to cut this one. So if this is the perpendicular to the anatomical axis, you have 6 degree valgus aligned this box like this to align itself to the perpendicular to the mechanical axis. And this has a slot for a jig which comes over the distal femur, anterior aspect of the distal femur, and whatever change you do here, it is reflected on the jig which is attached. Getting na? Getting? Okay. So it is like that. How much you change here, it is extended like this on this jig. Okay, so likewise, you adjust this jig and it has a saw capture, and you do a distal femoral cut. Okay, so there is a new concept that a fixed valgus cutting is not sufficient for all the patients. And they have proposed that you have to take a PBH X-ray for the planning of TKR. You might be wondering why. So what they have said is, if the neck shaft angle is around 130, 135, which is normal, so uh, now the 7 degree valgus, 6 degree valgus is accepted. But when you have something called as valgus or a coxa vara or a coxa valga, as you know, the neck shaft angle, as it decreases, the horizontal offset is differing. So center of head is here, you have anatomical axis is here somewhere. So the amount of distance between these two will change this angle. Agreed? So if you have a less of a this one, uh, what is that? You have a coxa valga, you know, the horizontal offset is less, so the center of head and the anatomical axis are somewhat close. So in this condition, it is assumed that this angle seems to be less. So if you still take a 7-degree valgus in them, it is that they will have some kind of a knock knee, So one thing is that almost their feet are near, the both side feet in a coxa valga are near because of their less horizontal offset. Almost these 2 feet are near. Upon that, if you make a same 7-degree valgus and knock knee, they'll start rubbing their medial aspect of the thigh, which is not acceptable. So if you have a coxa valga, so you will take a less valgus cut. Okay, the same with the coxa vara. Now the distance between this and this, the horizontal offset is more. Okay, so here if you take the same 7-degree, you hardly get to the neutral. You will not have a valgus because the angle between the mechanical and the anatomical axis is now bit more because of the increased neck shaft, the decreased neck shaft angle and an increased horizontal offset. So here it is the tendency that you will take. It is advised that you will take a more of a valgus cut to get into the valgus alignment ultimately. Okay, this is a new concept. Yeah. So this is how you do a distal femoral cut. So now you have something like this, and this gap, as we discussed, is the extension gap. So if everything is normal, then this should be around 18 mm, replacing a 9 mm of femur and 9 mm of the tibial side. If preoperatively there is a correction of the valgus and there is no issues with the soft tissue balancing, you will take a 9 mm cut on the tibia, 9 mm cut on the femur, and it is assumed that the extension gap should be around 18 mm. Now you will measure it. So you have now you have to measure this. You have a simple laminar spreader which you can use with the gradations, or you have a spacer blocks which you can use, and they are named like 9 mm, 10 mm, like that. That means 9 mm is a real 18 mm block. The thickness is an 18 mm block, but they say it is a 9 mm block, 10 mm block. It is like that because it is divided into two halves, and like that, to maintain the joint line. That's it. So you take a 9 mm spacer block and you measure it, and you see, is there any recurvatum, is there any flexion deformity. If that is there, how to address, we'll just talk in a bit while. But for now, we assume that the extension gap is around 18 mm, and 9 mm spacer block is what is perfectly matching it. So now you will have to match the same thing in the flexion gap, and you have already taken an IMM of proximal tibial cut. So when you already know that the gap here is 9 mm, and you'll have to have a 9 mm more cut from the femur to have a similar or the same flexion gap as of an extension gap. And here you have a cutting block, which first sizes this anteroposterior diameter. The How it is done is, first you have something which measures the total anterior and the posterior thing, and with that you have something called anterior referencing and posterior referencing. We'll talk in a bit. And with one of these, it deducts that by using one of this, it tells that and it will give a size of this size of the implant based on this anteroposterior measurement that decides the size, and the size is uh, calibrated in a such a way that if you use that size 4-in-1 block, it cuts the this distal femur 9 mm. Okay, so it is like that. So you will first measure the anteroposterior diameters, and based on that, you have a size of the femoral component and a matching uh, cutting block for that size, which you upon using which eventually cut this 9 mm. Okay, so what we have to do is we have to use that, and we measure the anteroposterior diameters, and we get to know the size, and then we use that sized 4-in-1 block to cut it. So before that, I would like
9 mm depends on the size, thickness of the implant, right?
yes, this 9 mm is the thickness of the implant.
It vary according to company.
Mostly it is 9 mm, but
it will vary according to the
it varies according to the implants, but most of them will usually have a 9 mm. There is some a uniformity kind of a thing. So now with for this posterior condyle cut, you have something called as anterior referencing and posterior referencing. What they are is, in anterior referencing, uh, there is slight bulge, and then you have a posterior condyle like this. This is taken off, and the anterior referencing is nothing but this anterior cut is the reference. Anterior cut is the reference. So a upsize or a downsize will cut the distal femur with respect to the anterior line, this anterior reference. If this is size 3 and this is size 4 and this is size 5, so the change in size is exclusively changed by the cut taken in the distal femur, keeping this as a reference. This is anterior referencing. Okay, so the posterior referencing is you take a posterior cut, and the further sizes are changed by the anterior cut. We keep this as the reference. And we change in the anterior. So this is size 3, this is 4, this is 5. It is like that. Okay. So which cut among the anterior and posterior is taken as reference is the basis for this anterior and posterior referencing. So as you know, what are the advantages and disadvantages? Like, why these two concepts came is because sometimes what happens is okay, many of the times we use anterior referencing. Why? Because to prevent notching. What happens is if you use a posterior referencing and you feel that due to some reasons, some issues with the balancing, and you thought you now want to downsize it, then it will cut more of an anterior cortex, and this will create something like this. And this notching is a potential a risk for the supracondylar fractures. Okay, so to prevent this, we keep as an anterior cut as the reference point, taking all the due care of not making it notch by measuring the anterolateral ridge, and from there you take a cut. And the downsizing here will cut more and more of a distal femur, keeping this anterior as the reference. So then why there is something called as posterior referencing when this is of so much of issues? The only theoretical advantage is that uh, by downsizing it, you have some levy, but if you do it too much, then the insertion site of the posterior cruciate ligament is at risk. If you too much change, too much downsize it, then the somewhere the insertion of the PCL is on the medial aspect of the uh, in the anterior reference. Why there is posterior referencing is this this complication is not there in case of posterior referencing, though there is a risk of notching, but the only theoretical advantage is that you are not anyway gonna touch the insertion site of PCL. That is the only reason. But for all the practical purposes, we use anterior referencing because the issues with the notching are so terrible that if you cut the PCL, you can have a posterior substitute, PCL substituting to get away with. But the notching and the supracondylar fractures are terrible things to happen. And the one more advantages is that, I mean, one more theoretical advantage is that there is something called as a posterior offset, posterior condyle offset, posterior condylar offset. So the distance of this posterior condyle from the posterior cortex line is called the posterior condylar offset. And it is observed that you have to get back to this preoperative posterior condylar offset to have more of the uh, uh, range of motion, or a similar, or a simulate the matched this one a rollback of a preoperative condition, a preoperative situation. So in cruciate retainings, uh, restoring this posterior condylar offset is important for the range of motion. So this is allowed if you take a posterior referencing. But again, to emphasize that these all are okay, but the notching is a dreaded complication, and it should you take all care to not make it happen. Okay, so this is how you take a posterior condylar cut, and you have a flexion gap, and you can measure this flexion gap again with a laminar spreader, or with a spacer block. And there is a thing which is called, the spacer blocks, they are like dog bones like this. If you have seen them, they are like this. For one size, like there are two uh, two things. What are these two things? Ki, matlab, why there has to be two things for a same size? Is because that some people say that once you know it, and once you decide whether you're going to do a anterior referencing or posterior referencing, you place a, a okay, so you place a okay, so you place so, so pardon for a while, we have issue with the charger of the stylus. So meanwhile, I'll just talk 2-3 minutes. That then you will place this one two K wires, or markers on the distal femur and you change the sizer with the 4-in-1 cutting block. Okay, so and another thing which I have to tell is, if you remember this, the sizer is used in accordance with the posterior condylar axis. That it has a metal slabs which abuts the posterior condyle, and as you remember, you cannot take a cut perpendicular to the posterior condyle because that is 3-degree internal rotated. So in that sizer you have a dial, so that external that you can change, and normally the this transepicondylar line is 3-degree external rotated to the posterior condylar axis, so you dial it to a 3-degree external rotation, and you use that. This is very, very important because to have a symmetrical flexion gap between the medial compartment and the lateral compartment. So if you change this rotation, like say for example, if you take a cut according to the posterior condylar cut, then you will be having a asymmetric gap or an increased gap on the lateral side as compared to the medial side, because it is 3-degree internal rotated. So or otherwise, if you enthusiastically you keep more of external rotation, then you will be cutting more of medial condyle and less of lateral condyle, and that will create an asymmetric gap on the medial side with respect to the lateral. So the important aspect is the component rotation of the femur, that you have to have a symmetric flexion gaps on the medial compartment as well as the lateral compartment. So that is achieved only when you do a proper component rotation, and okay, so that is important. Okay, sir. I'll just write it down in a while. And one more thing is that it is said that most of the time the this varus valgus deformities will have effect on the extension gaps, but whereas once you flex it, so the flexion gap is more or less balanced. So it is an issue. The coronal deformities are an issue in the extension plane, the extension gap plane, not at the flexion. However, there is some effect in the extension plane also, but usually what is done is you balance the soft tissues in extension, and in flexion you have a balanced gaps. Okay, so what I was telling is ki, again this diagram is very important. Screen, are you able to see?
स्क्रीन नहीं दिख रहा है,
उसमें से करना पड़ेगा ना,
ऐसा करना था। अभी तो अपन कट्स में है। अभी तो कट्स में ना,
क्या बोल रहे हैं?
बैलेंसिंग कल बता दे अभी।
अच्छा ठीक है, चल अभी क्या समझा, अभी समझ गया क्या?
नहीं, अभी मेरे को थोड़ा 2 डाउट्स है।
नहीं एक मिनट, अभी किधर उसको तो खत्म कर देते हैं। एक मिनट, अभी स्क्रीन दिख रहा है ना, तो एक मिनट इसको बता देता हूँ।
आर के जो तूने अभी बोला है ना बिना डायग्राम बनाए, वो समझा दे एक बार, जो तूने 2-3 मिनट बोला है ना,
वही बता रहा हूँ कि अभी क्या करेंगे तुम। सो द थिंग इज यू हैव अ posterior condylar axis which is 3-degree internal rotated, so you will have to dial it to a 3-degree external rotation to you have the proximal tibial cut like this, so you will have to align it to the transepicondylar axis. Okay, so this 3-degree external rotation, you have a dial on that sizer and you dial it, and it has 2 holes for the anterior referencing and posterior referencing. So you will use one of them, and as you decided whether you are using anterior referencing or posterior referencing, and you put in a K wires or chota Steinman pins. You use a K wires in those holes, and you replace this sizer with a 4-in-1 cutting block. Okay, so yeah. So what I was telling is, if you don't consider this rotation, if you do it the way the posterior condyles are, then you will be cutting equally, and you have a increased lateral gap as compared to the medial gap. Or if you do over enthusiastically the excess external rotation, then you will cut this medial condyle more than the lateral condyle, and this is, so there is an asymmetric flexion gap on the both compartments. So this precise the component rotation of femur is very important, and you have some guide for this, like you have some checks intraoperatively that this pin which you have put, they have to be parallel to this transepicondylar axis. That is one. And second thing is, you have something called as a grand piano sign. If you have taken an external rotation curve, you will be cutting more of the anterolateral aspect than the anteromedial aspect. Then you have to have this what you will have to have this grand piano sign, and once you take the cut, you just eyeball it. It has to be parallel to the proximal tibial cut. Okay, so these are the some of the checks which you can use to assess whether we have taken a proper component rotation or not. Why this is important is, sometimes what happens in cases of revisions, you don't have these many landmarks. You may not have a proper, you will not have a condyles to abut the sizer, and in cases of valgus deformities, you may have a hypoplastic lateral condyle. So you'll have to keep all these things in mind before deciding the component rotation. So few things which can be used even in the worst case scenarios are transepicondylar axis is the constant thing which you can use. So the whatever pins you put, that has to be parallel to this, and you have a proximal tibial cut, so that has to be parallel to the anticipated cut which you're gonna use. Okay, and some people, what they do is they just want to confirm it, and they just want to make sure that flexion gap is balanced. So before taking a cut, what they do is, you have a box cut like this with a saw capture here, with a here for chamfer cuts, and you have a cut here, the 4-in-1 block, and you have a distal femur which is cut. Okay, and you have a tibia. And what they do is, before cutting this one, just maybe like this, you will have to cut. No? So what they do is, they put a spacer here, spacer block here at 90-degree flexion, and they check the anticipated cut will balance the flexion gap or not. The here comes something called as a negative block. That is that when you use this cutting block, you have something like this with a saw capture here. So ideally you are cutting at this level, but you are measuring space, you are measuring thickness from here with the tibia. So the this view I am telling you, this is the anterior bank view. So you are cutting here, though you are measuring from here. So you will have to adjust to this loss of around a mm or 2 mm. This is a negative block which is on the opposite side of the block. Okay, So the other side will be usually a couple of less than this anticipated, considering there is a loss of a of 2 uh, this saw, the petal strip below this saw capture. So this is a negative block, and many people use this, and they balance it, and they take a cut. So you have a flexion and extension gaps equal, and then you prepare it with the 4-in-1 block. You do a trial, and and in CR you, अभी क्या है कि मेरे को किधर रुकना पता नहीं, क्या करूं? रुक जाता हूं मैं कि सबका मेरे को लगता हो गया होगा, सैचुरेशन हो गया होगा. I think I'll stop now. I'll stop. I think I'll stop now. Okay, let me just tell you this, that एक minute. Just I will tell you this. There is a when you are doing a cruciate retaining, when you use this a pegless tibial base with a poly, a trial poly and a femur component, Richard Scott has described something called Richard Scott describes something called as polo test. So this polo test is push up and lift off. So when you do a trialing, and if you observe a lift off of the a tibial base plate along with the trial insert on flexion, that means there is a lift off. This tells there is a flexion tightness. Okay, there is a flexion tightness. What happens? You use a trial base, pegless trial base, and a क्या बोल रहे हैं? बता रहा हूँ. You have this one like this. You have a femur. You have a pierce with a trial implant and a trial base plate, pegless trial base plate. This is how the trials look. This has a handle which you keep it, and then you take it off. You put in a trial poly, and you implant the femur, and then you take this in the range of motion, and on flexion, if you observe a lift in this base plate or a poly in flexion, that means the flexion gap is tight. This is lift off. Lifting of this tibial poly because of the tight flexion. So this is lift off. So this tells there is a flexion tightness. And if there is no such lift off, but once you flex it and you try to pull the poly, and it is easily pulled off, that means there is a lax flexion gap. There is a lax flexion gap. There is a lax flexion gap depicted by the pull off. So this Richard Scott pull off and lift off test is what we do to assess the flexion gap tightness, and this if you are not using the spacer. Pull off is in extension. Pull off also is in flexion. You measure the extension gap with the extension spacer.
More larger
you are not worried about that. To know the flexion gap, you can use the spacer block with the 4-in-1 block, or you can use something called as a lift off and pull off if you have committed the cut already. You cannot use a spacer block once you have committed. You can use, that's not an issue. You can use. There is another way also to know whether the flexion gap is correct or not. So once you take the cuts and you trial it, and you take a range of motion, and if you see a lift off, then it is a flexion gap is tight. And if it is not lifting, then if upon just pulling, if it is coming out very easily, so then it is called pull off.
RK,
Okay,
RK,
bolo.
the polo test you are talking about, it is done with
Yes.
spacer block only, no?
No, it is done with the trial implants.
Oh, okay, okay.
It is done with the
Okay,
trial
okay.
implant.
Of the trial poly, okay, okay.
Okay, means
Yeah, the
trial implant
base plate,
along
the
with poly
trial
also.
poly and the trial femur.
Okay,
Okay,
okay, okay, okay. Whatever.
Okay, so okay, we'll end now. Thank you. What were
So,
the questions, by the way? हाँ, बोलो.